So hi everyone, this is Sandy presenting my Neurorounds today. So today I'm going to talk about the anesthesia for endovascular thrombectomy. So in terms of today, how we're going to do this, so I'm just going to start by indications for endovascular thrombectomy, the acute ischemic stroke, and the management of acute ischemic stroke. We'll talk about the advantages and disadvantages of different anesthetic techniques and the physiological targets that's recommended, controversies of using GA and EVT, and the common complications that can be found in the endovascular thrombectomy. So strokes, as you know, it is pretty common. So, from the Statistics Canada, it was known to be the 4th cause of death in Canada in 2019. And there are 2 kinds of stroke, the ischemic and hemorrhagic strokes. In 2008, international stroke trial showed that after 6 months, just over 1/3 of people who had strokes were alive and independent. And out of all these strokes that come to the hospital, acute ischemic stroke counts for about 85% of cases. And as you know, for these kind of cases, there's a critical reduction in blood flow due to the clot, and there's cell death within the ischemic core. The penumbras can remain salvaged for hours with the minimum blood flow that it gets, but time is sensitive, but they're super time sensitive. The anterior circulation is more frequently involved than the posterior circulation, with the MCA being the most frequent vessel that's been affected. And historically, the only option for reperfusion was the IV thrombolysis, and they had to be administered within the 4.5 hours of symptom onset. And only 20% of patients were suitable due to many contraindications, such as recent surgery, being on anticoagulation, being delayed presentation. And the success rate was pretty low, quoted about 30%. And for large artery thrombus, which were about 40% of ischemic strokes that presented, the thrombus were often very extensive and were unresponsive to the IV thrombolysis. So endovascular thrombectomy it's a relatively new procedure where blood clot and cerebral vasculature were retrieved by a minimally invasive method. So this is a simple diagram. So as you can see, the stent retrieval mesh is embedded into the clot, and they are used to pull the clot out of the artery into the vacuum catheter, and then the clot stent in the catheter is pulled out at the end. And I think this is a table from the HERM meta-analysis. It was published in 2016. It looked at 5 different ICTs and looked at the outcome at the 90 days for endovascular thrombectomy versus the standard medical treatment, which was the IV thrombolysis. And you can see that the adjusted odds ratio for endovascular thrombectomy is significantly higher at 2.49. And the number of patients needed to reduce 1 MRS score. And MRS score is a modified Rankin scale that measures the degree of disability and dependency after stroke, with 0 being no symptoms to 6 being death. And the number need to reduce the 1 score on the MRS scale was just 2.6. They also looked at the different mortalities. So the mortality at 90 days and risk of symptomatic intracerebral hemorrhage did not differ between the patients receiving the IVTPA and thrombectomy versus IVTPA alone. And even in the subgroup of patients over the age of 80, the benefit still remained for those who did not receive the IVTPA. And this is a review that was published in 2017. Sorry. And this one looked at the best medical therapy versus the functional outcome. So early RCTs published in 2013 failed to show improved efficacy versus IV thrombolysis, but this was attributed due to poor study design with regards to patient selection, older technology, and long delay from stroke intervention. And many landmark trials such as these came after introduction of new generation stent retrieval devices, and they showed consistently clear superiority of endovascular clot retrieval over the standard medical care, reducing disability at 90 days in patients with anterior ischemic stroke due to anterior circulation large vessel occlusion. And again, this is another meta-analysis that showed improved outcome when thrombectomy was performed up to 7.3 hours after symptom onset, but there was still clearly greater benefit with faster intervention. And patient with moderate infarct core volume with the aspect score 7 to 8 has shallower declining benefit with longer symptom onset through perfusion than patients with minor infarct core volume. And the aspects is just a 10-point quantitative topographical CT scan score used in patients with MCA stroke, and they start from 10, and 1 point is deducted from initial score for every region being involved. So higher the score, but less the volume that's involved for the stroke. And this is a recommendation provided by the Canadian Stroke Best Practice for acute stroke management. So they say for eligible patient who can be treated with EVT within 6 hours of symptom onset, they should receive EVT, and this is level 8, evidence level 8. And highly selected patients with large vessel occlusion who can be treated with EVT within 24 hours of symptom onset, and those with stroke discovered on awakening should receive EVT as well. And this is also level 8 evidence. In terms of indications for EVT, so there is no current evidence for use of EVT in pediatric populations. So every individual case should be assessed for the benefit versus risk for EVT. Premorbid condition criteria, so the patient should be functionally independent and life expectancy should be greater than 3 months to be qualified, to be indicated for EVT. For imaging, so EVT is for small to moderate ischemic core, and IC occlusion in the anterior circulation. And for basilar arterial occlusion, again, it's individual basis, and they should look at the benefit versus risk ratio. In terms of time to treatment, as mentioned, 6 hours from onset of stroke symptoms or last known well, so all patients who are eligible should be treated. For patients who are presenting within the 24-hour endo, the imaging should be considered. And if it has been more than 6 hours of symptoms but less than 24 hours, then it's kind of individual basis whether they should get treated or not. In terms of anesthesia options, so 3 different anesthesia options, local versus conscious sedation versus GA. But for all these cases, we should always remember that there's limited access to patient during the procedure. So we need long extensions most of the time. They all need standard monitoring. So if it's non-invasive blood pressure, the Canadian guideline recommend blood pressure to be measured at least once every 3 minutes. And if the patients are under GA, they do recommend invasive arterial monitoring, but this should never delay the procedure as time is brain. In terms of local anesthetics, if the patient is conscious and cooperative, the procedure can definitely be proceeded under local anesthesia. And what are the painful during the procedure? So groin puncture is painful, the conscious injection can be painful, and clot retrieval can be really painful. So we may need, if the procedure is being done under local alone, then we may need to give analgesia at these points. In terms of conscious sedation, so we always need to be cautious because neurological deterioration can be possible as stroke evolves. Short action agents are probably the best so that the patient can be assessed after the procedure is done as soon as possible. Benzodiazepine needs to be used in combination with analgesia, but as you know, the sedative effects can be unpredictable and they may show different reactions to benzos, and this may be difficult to titrate depending on the patient population that presents. In terms of GA, so this is recommended for patients who present with agitation, reduced GCA, bad nausea and vomiting, and posterior circulation stroke. And for all the studies, it has been shown that intra-procedure conversion to GA is associated with worse outcome. And as you can see, this is probably, there is a reason that we need to convert. And there is something about the stroke that's causing this conversion, and probably that's what leads to worse outcome. And for GA, endotracheal with RSI is recommended. So what are the targets that we need to keep out? So even it doesn't really matter which anesthesia technique is chosen. We really need to look at specific targets, and blood pressure is what's been constantly mentioned. The Canadian Stroke Best Practice Guidelines suggest blood pressure targets to be 140 to 180 millimeter mercury. And there was a single center study that was published in 2017. This study, it was a sample of 256 patients, and they did show that 10% drop in MAP from baseline was a strong risk factor for poor outcome. And they did also mention that in patients presented with lower baseline, maybe like patients presenting with a blood pressure 120 to 130, it may not be necessary to target blood pressure over 140. Other physiological targets, so O2 saturation should be maintained above 92%, normocapnia for patients under GA, and try to avoid hypercarbia for sedated patients. Euvolemia is recommended, and temperature should be kept normothermic between 35 and 37. And if they are febrile, they should be treated with antipyretics. The only thing I really didn't know was the glucose. So I think the guidelines do recommend glucose, blood glucose, to be taken for all stroke patients. And if they are over 7.8, they should probably be considered for insulin administration. And these are all class 2 recommendations. So I guess this is where the most of the controversy and most of the studies are probably being directed right now. Is it GA versus congestion? The effect of anesthetic on outcome is very controversial. The previous older studies did show worse outcomes in patients with GA. But all these studies were highly observational. There are observation studies, retrospective reviews, and really not much details about like other variables that may be important for outcomes, such as blood pressure, the respiratory variables, the drug use were not very known. And there is highly concerns for selection bias. Because GA groups had higher NHSS scores, they have more severe strokes, there's higher proportion of posterior strokes. So like mentioned before, like there is a reason that people were probably getting GA, and maybe that was what leading to worse outcome than before. And this makes sense for this because most of these studies were observation studies. So there was a subgroup analysis that was done. And for modern thrombectomy devices, these studies shows no difference for GA versus congestion in 90 days for functional independence. But still, with the best available evidence, the Canadian Stroke Guidelines do recommendation, or like do say the sedation is generally preferred. So I'll just mention a couple of RCTs that was been done about this topic. So CSS Study published in 2016 was an RCT of 150 patients. The primary outcome was NHS score after 24 hours, and secondary outcome was MRS and mortality at 3 months. For primary outcome, it did not show an advantage for conscious sedation over GA for endovascular thrombectomy. But this was criticized for small size, single center, and it was very early primary endpoint assessment. Next study done in 2017, END-STROKE study, again, RCT of 90 patients, again, small study. Primary outcome was MRS score after 3 months. Again, no significant difference. And I think it was mentioned that this study was not really designed to establish non-inferiority. Goliath study in 2018, 128 patients looked at the difference in median infarct growth with a secondary outcome of MRS at 90 days. Again, with primary outcome, there is no significant difference between GA and conscious sedation. It was, again, the single center study, small size, and may have an underpower to detect difference. And HERMS collaboration. So the HERMS study that I did show you before, so the group did a subgroup meta-analysis for patients. So they found about 797 patients who were either treated with GA versus treated without GA. The primary outcome was MRS in 90 days, and outcome was better for patients who did not have GA. Again, this study was pretty old and may have been used technology that was different from what's being used right now. So this was a meta-analysis, I think, published in 2019, I want to say. And they looked at the effect of general anesthesia versus consultation for the outcome of acute ischemic stroke. And it included the 3 studies that was mentioned previously, the CSS study, the end stroke and Goliath study. And this is just one graph. So it's showing all the MRS score. So in the end, they included 368 patients from those 3 studies, and showed that the patient actually under GA had a better MRS score at 3 months' time than the patient who had it under conscious sedation. So odds ratio 1.81 for modified ranking scales from 0 to 2 after 90 days. And also one of their secondary outcome was looking at the successful reperfusion. And people who were getting the EVT under GA had higher odds of having a successful reperfusion as well. And they all looked at the possible complications, and there were no significant differences of anesthesia or intervention complications such as vessel dissection or perforation, SICH, migration of embolus or new territory to the new territory, and post-op pneumonia. And even mortality after 90 days, they didn't show any differences between 2 modes of anesthesia. GA or consultation continuing. So, like mentioned, the higher rate of successful perfusion in GA group, and GA associated with greater technical success, and it may be attributed to complete patient immobility that we're providing with a GA rather than conscious sedation, because with the degree of sedation we're providing, sometimes patients do move and you may have to just sedation, and the proceduralists may not be able to concentrate fully on their procedure, but rather than like have to talk to the patients during the procedure as well. So that may have been a factor. But we all know, even from all this study, we all know that there are factors outside of the mode of anesthesia that we're providing that is associated with the outcome of EVT. So hemodynamic disturbance is pretty significant. The time between onset of symptom and having the access to EVT is also very significant as well. And for this meta-analysis, even though it's a meta-analysis, like mentioned, it was about only 370 patients who were included. So the study is limited again by a very small sample size. And I don't think they were able to look at the blood pressure during the cases because they were not provided by the studies prior. And again, the time to treatment, that is also an important factor, as we know, was not provided as well. So take the conclusion with the caveat that we don't know all these other confounding factors that are associated with the outcome of stroke. Just moving on to different topics. So common complications or common or uncommon complications associated with EVT. So intracranial hemorrhage reported up to 10% of patients, and they can be from device-related arterial injury from instruments, or can be spontaneous, such as hemorrhagic transformation of the stroke. Vessel dissection is also possible, and they can be from like during catheter or wire manipulation. And it can involve any vessel from puncture to groin site usually to the intracranial vessels. And increased risk of occlusive or thromboembolic complications as well with a vessel dissection. Vasospasm is also possible due to vessel irritation, but it usually resolves with withdrawal to catheter, and further thromboembolic events is also possible during the EVT. And trauma, and it can be at very level, like at different levels. So at the groin axis side, there can be for sure trauma, but we shouldn't really forget about all these rare cases of trauma, such as a retroperitoneal hemorrhage, the aneurysm, and limb ischemia. And because we're giving drugs, they're giving drugs, adverse reaction to drugs that are given, including anaphylaxis, can happen. And with the conscious sedation or GA, we can always have anesthetic complications such as respiratory depression, airway obstruction, aspiration events, hemodynamic instability, and patient movement. So in summary, EVT is a relatively new technology that leads to better outcome for selected acute ischemic stroke patients, but time is still brain. And in terms of GA versus sedation, old studies did show worse outcome for GA, but it was from poor quality data, observational studies, and probably had selection bias that the studies could not account for. Newer studies seem to indicate equivocal outcome or better for GA. But again, these studies don't really show, hasn't really showed any data for hemodynamic, hasn't really accounted for hemodynamic stability or time to getting treatment. Again, what's really important is time is free. And there are, it's the other procedures and complications can still happen. So situational awareness is very important when we are providing anesthesia for this procedure. And that's it. Thank you. And a lot of papers that I've referenced on. Thank you so much. So if you have any feedback or questions, I will periodically check the email that I'm getting the feedback from. So please do please feel free to provide me with the feedback, and hopefully I can answer them. Thank you.